Good morning and welcome to Methodist DeBakey Grand Rounds. I am Sherif Nagueh and I have with me John Buergler. We are happy to host Grand Rounds today, and we have a great speaker with us, Dr. Naidu, and we'll introduce him shortly. Dr. Buergler will have some announcements regarding how to send us your comments and questions.
Yes, so please join by web. Go to capital POLL, capital P, capital EV.com, enter DeBakey and respond to activity. Also, please join by text. Text DeBakey, D-E-P-A-K-E-Y, in caps, to 37607. Text DeBakey to 37607 and text in your message, and we will get to as many questions as we can. Thank you for being with us at Grand Rounds.
Introducing Dr. Naidu now. Dr. Harry Naidu is professor of medicine at New York Medical College in Valhalla, New York. He graduated from Brown University in Providence, Rhode Island for both undergraduate and medical school. As part of the 8-year program, he was a resident at New York Presbyterian Hospital in Manhattan, and then cardiology and interventional cardiology fellow at University of Pennsylvania. After several years as attending at New York Presbyterian, he moved to Westchester Medical Center and New York Medical College, where he runs the Hypertrophic Cardiomyopathy National Center of Excellence and is director of the Cardiac Catheterization Laboratory. He has published over 200 original manuscripts, book chapters, and review articles. He holds several professional roles, including trustee of the Society of Cardiovascular Angiography and Interventions, trustee emeritus of Brown University, and past president of the Brown University Medical School Board of Directors. He is also president of the New York chapter of the American College of Cardiology, where he represents cardiologists in New York on several advocacy and educational initiatives. Dr. Naidu has strong interests and important contributions for alcohol septal ablation and is nationally recognized as a leading authority in hypertrophic cardiomyopathy. Please join me in welcoming Dr. Naidu, who will give us his presentation now.
Thank you, Dr. Nagueh, Dr. Buergler. Can you guys see my screen?
Yes.
Yes.
Okay, great. Well, it's a pleasure to be here. I have several friends there, and I wish I could be there in person. But I love this topic, and I hope we can have some good questions towards the end. So I'm going to get started. So the topic is septal reduction therapies for HCM in the era of novel therapeutics. I think you all know, or many people know, there's several drugs on the horizon that are fairly promising. So, but at the same time, there's been an evolution of septal reduction therapies, and I'll take you through that story. And then we can figure out towards the end, how do we want to treat these patients in the coming years? So for the general audience a little bit, the definition of HCM, the etiology, and the impact. HCM is defined by any LVH of greater than 1.5 centimeters. Certainly, even in a family history of HCM, if you have more than 1.3 centimeters of thickness in any area, we're a little bit more concerned about early HCM. HCM typically perturbs heart function with characteristically hyperdynamic contraction, impaired relaxation, and reduced compliance. It is caused by dysfunction of the sarcomere, and we'll talk a little bit more about that as we go along, including some recent studies. On a basic level, there's a normal sarcomere, as you can see here on the left, with normal contractility, effective relaxation, and ordered sarcomeres. And then you have dysfunction in sarcomere proteins on the right, which is the HCM sarcomere. This is typically pathognomonic as too many myosin acting cross bridges, which causes hypercontractility, impaired relaxation, disordered sarcomeres, cardiac tissue stiffness, and interstitial fibrosis. In terms of prevalence, it is thought to be a relatively common disease these days. Historically, we thought it was very rare, but it turns out it'll probably be about 700,000 to 1 million patients in the United States, which is a large number of patients considering our population. But importantly, it's a global disease. It affects about 1 in 200 to 1 in 500 individuals, somewhere in that range, across all races and ethnicity, and across all ages and both genders. And you can see here, there's probably only about 100,000 patients diagnosed, with another 600,000 undiagnosed in the community at various stages of illness and at various ages. Again, the hypertrophy typically has to be 1.5 centimeters thick in any one area, and we'll go through where those areas typically are found. And in large population studies, getting over 1.5 centimeters without other significant causes is very rare. So patients with more than 1.5 centimeters, especially when there's asymmetry and normal thickness in other walls, is typically fundamentally hypertrophic cardiomyopathy. As mentioned, over 1.3 is typically required for diagnosis in a family history with a higher likelihood of hypertrophic cardiomyopathy. And finally, in kids, as they're growing, we typically use Z-scores, which is basically standard deviations against the mean. There are typically 4 phenotypic forms that we generally talk about in hypertrophic cardiomyopathy. The most common being the sigmoidal HCM, which is 40 to 50% of patients with a fairly thickened basal septum, but relatively spared other walls of the heart. The reverse curve, seen in mostly younger patients with certain genetic mutations, where you see a reverse curve into the LV, as you see there, with relatively massive thickness more in the mid-ventricle and then tapering more in towards the apex. The apical HCM, which is present in about 10% of patients, where the LV apex is a predominant hypertrophied segment. These may be associated with apical aneurysms and also with midventricular and more distal obstruction. And finally, a neutral curvature, which is the hardest to diagnose because it's oftentimes missed based on the fact that it's fairly thickened throughout and may be mistaken for severe hypertensive heart disease related hypertrophy. Echocardiogram is the mainstay for diagnosis. However, MRI is gaining a foothold and has been increasingly used for diagnostic purposes, as well as sudden cardiac arrest risk stratification. The EKG is typically can be pathognomonic in these patients. You see a normal EKG on the left, you see possibly HCM or LVH in the middle, and then finally patients with HCM will have oftentimes what's called a pseudoinfarct pattern with Q waves, oftentimes in the inferior or lateral leads. You'll see LVH, you'll see a characteristic T wave inversions. And these inversions can be very pronounced, especially in the apical HCM patients. Importantly, the EKG, if you look very closely, is typically abnormal in 90 to 95% of patients. That doesn't mean it has to be pathognomonic, but if you have a stone cold normal EKG and a completely normal echo, you can effectively rule out the phenotype of HCM. Of course, you cannot rule out the genotype, but you can typically rule out the phenotype. And MRI is helpful in that as well. So it's important to distinguish obstructive versus non-obstructive HCM. And over time, it was fairly debated whether obstruction was very important in this disease process or how frequent it is. But it turns out that it is a very important component of the HCM physiology as well as the prognosis in these patients. So obstruction occurs when the thickening of the ventricular septum and SAM, systolic anterior motion of the mitral valve, decreases LV stroke volume by both diastolic dysfunction and narrowing of the outflow tract. And this is seen in roughly 70% of cases of hypertrophic cardiomyopathy. If obstruction cannot be provoked, then you have about 30% of patients with non-obstructive HCM, where the typical problem is diastolic dysfunction. The definitions and terminology for obstruction is typically if you have over 30 millimeters of mercury of obstruction from the across the outflow tract or anywhere in the intracavity coming out into the aorta. So if you have resting obstruction, seen in 37% of patients, they have more than 30 millimeters of mercury gradient at rest at all times. Latent obstruction are patients with less than 30 at rest, but greater than 30 under physiologic provocation. And then finally, non-obstructive patients are patients who remain less than 30 millimeters of mercury at rest and with provocation. You cannot elicit a higher gradient despite any types of maneuvers. The reason 30 millimeters is required is because you can have some physiologic obstruction under even in a normal physiology in a non-HCM patient just due to dehydration, drop in preload, and or hypercontractility. This slide is important because it typically shows you how these patients progress. Typically, from the genotype, they will have excessive actin-myosin cross-bridging. This is the bottom left. And as time goes by, this converts to hypercontractility, leading to thickening of the cardiac tissue, hypertrophy, abnormal relaxation of the heart. And then finally, at some point, it gets worse and you have reduced stroke volume, outflow tract obstruction in some patients, mitral regurgitation, and eventually atrial fibrillation. And these cause varying degrees of heart failure. The symptoms include dyspnea, fatigue, chest pain, palpitations, and syncope, and various complications, including heart failure, as time goes by, arrhythmias that increase over the course of the patient's lifespan, stroke related to such arrhythmias, and finally sudden cardiac arrest, which can happen at any age point, but can happen from a variety of causes. This diagram shows you where obstruction fits in and why obstruction is important to target in these patients and why medications and septal reduction therapy have moved in that direction over the years. As we already mentioned, the genetic disorder causes HCM, which is a diastolic dysfunction problem, a hypercontractility problem, and reduced cardiac output and stroke volume, resulting in forward heart failure or easy fatigability. Over time, these patients have asymmetric hypertrophy in a large portion of patients, as we described, from SAM and LVH of the septum, resulting in obstruction. This does two things. The obstruction causes a positive feedback loop that causes more LVH. So you have an initial primary LVH from the genetic predisposition, and then you have secondary LVH, as you would in someone with AS, but in this case, because of subvalvular outflow tract obstruction. So that causes a vicious cycle. In addition, the obstruction causes other problems. For example, the mitral regurgitation happens only in those patients with obstruction. Atrial fibrillation is higher incidence because of the left atrial strain and dilation over time. Pulmonary hypertension due to secondary elevation of the filling pressures on the left side. Lower cardiac output because of the MR as well as the stroke volume reduction. Intermittent hypertension and syncope because of the drops in pressure. And finally, the incidence of sudden cardiac death also goes up in these patients once they have obstruction. Heart failure is seen in a large proportion of patients, and again, this is age dependent and disease dependent and anatomy dependent. 22 to 45% of patients in studies have been shown to have heart failure with hypertrophic cardiomyopathy, 4 to 33% of patients with atrial fibrillation, 20 to 30% of patients will have non-sustained VT, which is fairly frequent, and finally 4 to 9% of patients have stroke. And indeed, stroke is the third leading cause of death in patients with hypertrophic cardiomyopathy because of this unrecognized AFib that is a high risk for large clot burden. Although sudden cardiac death is uncommon, about 1% of the general HCM population, HCM is associated with an all-cause mortality of 3 times higher than that of the general population. And so it's very important to assess for their risk of heart failure-related, stroke-related, and sudden cardiac arrest-related causes of death in this patient population. This shows you a little bit diagrammatically about how we take care of these patients. We look to see if they have symptoms, and these are the typical symptoms we find. And then the pivotal point here is whether they have obstruction or not. And as you can see here, 70% of patients have obstruction, 30% non-obstructed. Regardless of the type, they get pharmacologic therapy. And if they have refractory symptoms, we start talking about invasive therapies. Ideally, in some patients, heart transplantation, myectomy in some patients, and alcohol septal ablation in some patients. Importantly, there is no current management options that target the underlying pathophysiology of HCM. And this is where some of the medications may come in the later part of this talk. Another way of looking at these patients and how you would maybe take care of these patients in the office is looking at the total pie. If you have all HCM patients, we want to make sure we re-stratify them for sudden cardiac arrest as they come in. We want to assess their symptoms and their phenotype and why that phenotype is causing the symptoms. Very important to understand what is going on an anatomic and hemodynamic standpoint, which doesn't just include the heart, but also includes over time the lungs, volume status, and other issues such as the interaction with the kidneys over time, because this is a heart failure condition. And that's important to recognize. It's not just a heart condition. Family screening and genetic testing, you don't want to miss out on this. So this is why comprehensive programs need to have all of these available. And AFib and VT surveillance and management. And then really, if they're obstructive, we have a lot more to deal with in terms of their symptoms. We can use medical therapy in escalating doses and types. We can use septal reduction therapy, such as myectomy and alcohol ablation. The non-obstructive patients is medical therapy, and in rare cases, we can do apical myectomy, which we've done about a dozen of them here at our institution, and then heart transplantation if their CPET shows severe debilitation. There is also a drug refractory end-stage form, and by end-stage, we typically mean that the EF starts going down. So they move from a hypercontractile state to a normal contractile state or even a reduced contractility state. And these patients have a high risk of sudden cardiac arrest requiring dual chamber ICD. They may require cardiac resynchronization if it's thought to be maybe pacing related in some patients, or if they have a left bundle branch block. And then finally, heart transplantation in a subset of patients as well. Medications that we recommend in these patients as class 1, although it's all pretty much observational, is beta blockers as the primary recommendation. Verapamil, if beta blockers do not work or contraindicated. And then finally, disopyramide can be used with either beta blockers or verapamil. Our goals of therapy in these patients, typically short term, is to try to improve their symptoms. You want to get them from a New York Heart Association class 3 or 4 to 1 to 2, ideally 1. And you certainly want to get rid of any presyncope or syncope because that can be fairly dangerous for these patients, especially because it's abrupt. Ultimately, we want to improve their quality of life and exercise tolerance, and we have lifestyle modification, medications, and invasive therapies to do this, as well as antiarrhythmics or EP ablation if palpitations are a significant burden. From a long-term standpoint, this is where we're moving with this field, is what can we do to regress LVH? What can we do to remove fibrosis or reduce fibrosis? And what can we do to regress the global wall thickness in these patients? Can we improve prognosis, i.e. survival? Now, we know we can do some of that with ICDs in patients with high risk of sudden cardiac arrest, but do septal reduction therapies also improve prognosis? There is some evidence that, at least observational and based on the selection of patients that we have currently, that might be the case. So I'm going to focus on pharmacotherapy a little bit early and then come back to it, and then septal reduction therapy primarily, and then finally a little bit about the novel medications that are coming down. So the current pharmacotherapy is basically beta blockers, and we typically use toprol, in some cases atenolol. I tend to stay away from the bistolics and the non-selectives because they may have more tolerability, but it's hard to judge their level of decreased contractility versus their level of afterload reduction, and their effect on the gradients. So generally, beta blockers and BID dosing, they are first-line agents that increase diastolic filling and decrease contractility, reducing provocable gradient. Calcium channel blockers do the same thing. However, there's a caution to not use high doses, because as you go from small to moderate doses to high doses, you may actually have a larger effect on the afterload reduction, which causes more obstruction in some patients. Finally, disopyramide, trade name Norpace, is a very good antiarrhythmic that works both on prevention of AFib, but also on reducing contractility. And importantly, it seems to reduce contractility both resting and latent, as compared to beta blockers and calcium blockers, which really block the adrenaline-related provocable gradient. So oftentimes these are used in combination. The problem is really side effects of some of these medications. One final word about diuretics. In medical school, and there may be some students in the audience, we typically teach no diuretics in these patients. Diuretics may cause drops in preload that increase the obstruction, causing more syncope and more heart failure. However, as I mentioned, as patients age, the diastolic dysfunction, the drop in stroke volume, and the overall reduction in cardiac output in these patients tend to lead to fluid retention and hypervolemia. So it's important, once you get past 50 years of age or so, to assess for fluid status and not just assume these patients are always dry or euvolemic. Oftentimes, at over age 50, if they've been living with disease for some time, they typically are hypervolemic and require some degree of diuretics. This is the main data on Norpace from Dr. Sherif's lab in NYU, essentially an observational study looking at use of Norpace over time, that there was no signal for increased arrhythmia burden in these patients. So this really showed that it can improve the gradient in some patients. Maybe about half of patients seem to have some benefit, and the rest of them didn't have as much a benefit, but the benefit is somewhat meager, as you see here. So the problem with current medications is that compliance can be a problem. It's oftentimes BID dosing. There are side effects of medications, particularly beta blockers in young individuals: fatigue, impotence, bronchospasm, and bradycardia with lack of chronotropy. Constipation, bradycardia, decreased chronotropy, and fatigue with calcium channel blockers. QTC prolongation with Norpace, which can cause torsades, and I've seen that happen, so we have to be very careful about that. Norpace also has a lot of other side effects which can hinder tolerability, especially urinary retention in patients with BPH. And importantly, the medications do not modify the underlying substrate, at least the medications we have to date. And also, they really only work while taking the medication. And as we get older, some of these patients end up having other problems. They may need their gallbladder removed, they may need an appendix removed, they may have other GI surgery or cancer or whatnot. And the problem is then, how do you stop these medications, which are oral medications, when these patients are NPO, and take them through surgery with the heart that becomes obstructed again? So an increasing concern is really, how do you manage these patients as they get older with obstructive HCM with just medications that are oral only? There's also a difference of opinion on how to use medications. Some places go right to septal reduction therapy, and this would be such as Mayo Clinic. Our hospital is probably more aggressive at moving more towards septal reduction therapy, either myectomy or ablation, compared to continued medications. But there are other places that use a lot of medications. They may take beta blockers, add calcium blockers, add Norpace, and get the patients feeling reasonably well. So there's an art to this. And it also, I think, importantly, depends on how good you are at these procedures. I will show you that there is a variability about procedure outcomes depending on volume. And so it is very reasonable, if your volume is not that high, to pursue medications until you get that expertise in your vicinity. So going into some production therapy, which I think our audience will be very interested in, I got involved in this essentially as a fellow at University of Pennsylvania, where we were doing maybe 5 a year or so. It was the early days. As you might recall, alcohol ablation was really first described in only 1996, and I think I was a resident in 1997 to 2000, so we really just heard about it. And then I was lucky enough to train in it and learn it at my fellowship. And then from there, started doing them, not with a goal to be an HCM expert, but rather it was a fascinating disease process. Over time, we started an HCM center at Cornell. I was fortunate enough to be on the guidelines after that. We started an ASA training course, which Dr. Nagueh is part of. We launched an HCM textbook in 2014 that now has a second edition in 2018, and we'll be starting a third edition sometime next year. And then, as you know, there are now new medications in this space. And we continue to do about 40 to 50 now alcohol ablations a year. Pretty much every week we have an alcohol ablation, and we're doing about half that number in septal myectomies, which we launched a little bit later. But I've been doing it for about 4 years now. So for those in the audience who haven't seen an alcohol ablation, this is a patient with a typical severe gradient. The gradient is dynamic, meaning it's variable based on respirations and provocations such as the PVC. So post PVC, you have the Brockenbrough maneuver with a large increase in gradient, but really a characteristic drop in the stroke volume. So you see the pulse pressure goes down. That's the sign of the Brockenbrough maneuver. This difference here is less than this difference here, showing that less blood got out of the heart. And that only happens really in hypertrophic cardiomyopathy. This is after alcohol ablation, resolution of gradient. And if you see a year later, this is a 1-year echo from one of our earliest cases showing that the septum that was mid-septum, about 1.5, was about 2.0 here. And then over time, it's come down to 1 centimeter. It looks like a myectomy result, but this is an alcohol ablation result, one of our earliest patients that is still following us here today. So again, I was on the 2011 guidelines with a few other excellent colleagues, and there was a lot of debate about who gets alcohol ablation and myectomy. So typically the indications are the same on a global sense. You have to have severe symptoms, typically class 2 to 4 symptoms of heart failure. They have to interfere substantially with the patient's life. Also significant angina is reasonable, as well as presyncope and syncope. They should have a septal thickness of at least 15 to 16 millimeters. They have to have obstruction of over 50 millimeters of mercury, because less than that implies that it's not likely to be the culprit in the heart failure syndrome of these patients. And they typically should have the basal septal hypertrophy and systolic anterior motion of the mitral valve, although, of course, myectomy can be used to work on mid-ventricle obstruction as well in these patients. Alcohol ablation has been around for 25 years or so now, a little bit more. It's minimally invasive. It requires significant expertise, as well as a team-based approach with echo guidance and EP. It avoids general anesthesia and intubation and sternal incision and healing. It maintains the clinical benefits of surgery, ideally when done in appropriate patients, and it's widely shown to reduce cost and length of stay in patients with hypertrophic cardiomyopathy. Alternatively, surgical myectomy is performed even longer. It is fine-tuned at centers of excellence and done quite well. I'm very proud of our surgeons here. Our outcomes have been excellent as well. It does have symptom improvement and long-term survival results that are all comparable. However, it requires sternotomy and intubation and associated morbidity of that and some healing over time. And complications from above are riskier in older patients and those with comorbidities. Typically, the myectomy has moved from being a single cut to being a second cut, going deeper into the septum, to the base of the papillary muscles, to make sure that all of this area is thinned out and there's no area of residual obstruction in these patients. And in some institutions, there is some plication of the anterior leaflet. If the anterior leaflet is too long, and reduction in the cords or moving of the papillary muscles. In our institutions, we tend to do it like the Mayo Clinic, which is to avoid involvement in the mitral valve unless after removing the muscle, there is evidence of residual obstruction. In those cases, they will then tackle the mitral valve, but that's in single digits in our institution. But this is what happens. If you do alcohol ablation or myectomy, you interrupt this cycle. You can regress LVH, which improves diastolic function, and you can also decrease obstruction, decrease symptoms, and decrease LVH, as I mentioned. And this is the proof of that, and it's been repeated many times as some of the early studies showing that after alcohol ablation, within 6 months, you not only improve diastolic function, but you also reduce both the septal mass where you did the ablation and the mass of LVH in other more remote areas that were not ablated. So this is the regression of LVH that we see distant to the site of ablation. It's a global process that improves over time and has been shown to continue to improve over 2 to 3 years. This is an important point because patients, for example, who require diuretics will continue to require diuretics for 2 to 3 years after their procedure, be it surgical myectomy or alcohol ablation, as the diastolic dysfunction improves. Importantly, these procedures do improve the VO2. So you can see here, myectomy seems to improve it by about 6 points, alcohol ablation by about 4 points, and exercise and bi-beat pacing about 1 to 1.5. Now, it is important to note that you would see here that, oh, is alcohol ablation not doing as well as surgery? But you have to also remember that the peak VO2 is different for the two populations. The mean age of septal myectomy in this country is somewhere between 35 to 45, and the mean age of alcohol ablation is somewhere between 56 and 65 or greater. So their VO2s at baseline are somewhere around 20 to 30. So a difference of 6 improvement in the VO2 of a young person is about 20% improvement, and the difference of 4 in an older person is about a 20% improvement. So I would just say that in general, these procedures improve the VO2 about 20%. This is from Dr. Nagueh's overall original observational analysis, and I know he's one of our moderators and good friend here. And Dr. Buergler, I know you work with Dr. Spencer. So this is from your data, showing essentially, and you're on this as an author as well, in 874 patients, about 95% improved in New York Heart Association class 1 and 2. Remember these numbers as we'll compare them to the medications later on. The procedural mortality was well within 1%. This is despite an early learning curve for this procedure over decades. Pacemaker implantation rate 9%, which decreased from 28% in the early era to 6.5% over time. And there's been a lot of improvement in techniques even since this time, including reduced alcohol use, targeted septals, myocardial contrast echo guidance, which I use to a large extent, probably 90% myocardial contrast echo and echo guidance compared to fluoro, very little fluoro used in my procedures nowadays, and active fixation TVP. All these reduce complication rates in this population. There was a lot of debate for a while about alcohol ablation versus septal myectomy, but I'll go fast through this because this is fairly resolved now. This is from Cleveland Clinic, Samir Kapadia and Nick Smadira, who's a surgeon, and Milind Desai, looking at alcohol ablation versus surgery in the early to mid days, showing that they really didn't find much difference between the two, and the choice should be left up to the operator and the patient. This is an elegant study from Andrew Wong's lab in Duke, their HCM program, showing again the sudden cardiac death after invasive therapy is about the same with alcohol ablation versus myectomy. In fact, after adjusting the odds ratio, alcohol ablation patients tended to do better than surgical myectomy. And this is some of the early data that not only is it safe, alcohol ablation, but it may be comparable to surgery. Then the Mayo Clinic, and this is Paul Saraja presenting this, I think this was at TCT one year, showing that myectomy and ablation both have about an 80% survival at 8 years. And this survival is the same as the expected age and gender matched population without HCM in the general population, showing that for the first time, these patients who are the sickest of the patients with hypertrophic cardiomyopathy may be able to normalize their survival curves at least over the first 10 years with these procedures. And that ablation and myectomy are probably about the same. This is another study from Rick Nishimura and Paul Saraja at Mayo Clinic. And then they also looked at the overall comparison in Circ Journal here in 2018 between surgery and alcohol ablation. And some differences do come up. It does seem to be that pacemaker rate and redo rates do favor surgery, much less redo rates and pacemaker rates with surgery in expert centers. 30-day mortality favors alcohol ablation, as one might imagine. And sudden cardiac death rate appears comparable. A larger review here in 2015 showed the same thing. The rate of all-cause mortality is about 1.5% per year with alcohol ablation and 1.4% per year with surgical myectomy. And if you look at sudden cardiac death and aborted sudden cardiac death rates, you have about 0.4% per year in alcohol ablation and 0.5% per year with surgical myectomy. But however you cut it, it looks like overall mortality long-term between the two procedures is about the same. So this is how we design at our institution. This is a paper we came out as a review article a couple of years ago, taking a multidisciplinary team approach to patients with hypertrophic cardiomyopathy, including imaging, interventional cardiologists, non-invasive cardiologists, surgeons, all of our mid-levels. It's a fairly big meeting today where we present cases and we decide surgery versus ablation in these patients. We look at factors such as the age of the patient, the comorbidities, the risk for surgery, how bad is the obstruction and where is the obstruction, the precise anatomy of the mitral valve and the coronary anatomy, baseline EKG, pre-existing pacemaker or ICD, The patient's preference, which is one of the lower aspects of it, to be honest, these days. Hospital volume and expertise, severity of gradient, and septal thickness. And then there's some things that favor alcohol ablation and some things that favor myectomy. In our institution, alcohol ablation is reasonable, certainly in older patients with comorbidities. And these include the TAVR patients who require alcohol ablation before their TAVR for outflow tract obstruction. Those who are in middle age but have especially favorable anatomy, so those who I think have a very small septal bulge that can be easily amenable with an excellent coronary target for this. Certainly, if they already have a pacemaker and ICD in place, if I can give one cc or a half a cc of alcohol and get the result, same result as surgery, of course, we would go that route. Patients who've already had myectomy, fortunately, that's coming down in terms of what we see nowadays. Pre-existing right pulmonary branch block, if pacemaker ICD not already in place. Patients who understand the risks and benefits of both and qualify for both but favor alcohol ablation. And finally, prior to TAVR, as I already discussed. Surgical myectomy is only done in children, meaning that we do not do alcohol ablation in children. We have a cardiothoracic pediatric surgeon who does our kids here, such as Noonan syndrome and other syndromic HCM patients, and certainly is preferred in patients who are young, especially less than 30. Massive LVH patients, because it's typically hard to get rid of massive gradients and a large area of contact from alcohol ablation alone. Mid-ventricular obstruction, with or without apical aneurysm, requires surgery. Concomitant surgical valvular or coronary disease, membranes in the outflow tract. And this is not to say that small little attachments require surgical myectomy, but true membranes that are causing obstruction do require surgery. Anomalous papillary muscles, failed alcohol ablation that's brought in without any option for redo ablation. Absence of acceptable septal perforators, which I'll put an asterisk next to because I do get patients who are sent to me because of quote unquote absence of acceptable perforators, but we do find them. And then pre-existing left pulmonary branch block. The 2014 guidelines then moved both alcohol ablation and surgery to a class 1 indication, meaning that really for the same symptoms, you have to decide based on the anatomy and your center's expertise and the outcomes of these patients, which way to go. Both therapies are class 2A for current exertional syncope. This is in 2014. And myectomy was reserved as a class 1 only when other surgical disease is present. I will put here, though, as we decide who gets alcohol ablation or surgical myectomy, a few things have come up. One is that there does seem to be a difference based on gender. And this is what we published just earlier this year in JACC Interventions, looking at a large database showing that surgical myectomy and alcohol ablation mortality does seem to favor alcohol ablation, as you see here. Okay, but mortality by gender, again, is about the same in surgery, but alcohol ablation, men seem to do better in terms of mortality. Women tend to do worse, despite being adjusted for age and other comorbidities. If you look at the pacemaker rate, after myectomy, the pacemaker rate is higher than we see at centers of excellence, about 9% now. But interestingly, it's not gender specific in surgery, but it is gender specific in alcohol ablation. Men seem to have a much lower rate of pacemaker requirement after alcohol ablation than even if they had had surgery, and also against their female counterparts getting alcohol ablation. So we have used this data to incorporate it into our decision-making tree such that patients who are men, especially younger patients, we will oftentimes give them the option of alcohol ablation because myectomy may actually have a higher risk of pacemaker. Something to be interesting to talk about this in the discussion. I want to see your experience at Houston Methodist as well. So the current landscape in our practice is medical management with beta blocker until symptoms abate or side effects develop. It's better for latent obstruction, not great at reducing resting obstruction, and rarely, if I ever, add calcium blockers on these patients. The addition of disopyramide in older patients and those who can tolerate the side effects, especially if they have concomitant PAF, seems to work quite well at reducing AFib burden in these patients. At experienced centers such as ours, there's certainly been a move to earlier septal reduction therapy to improve symptoms, reduce AFib burden, and the need for medications, and perhaps improve both quality of life and survival. And this, again, makes life easier later when confronted with other diseases. So some of my easiest patients, they go through this curve where they're getting sicker and sicker. Then they get sick enough to get these procedures, and then they go all the way down to being my least sick patients. And then they don't see me as often, and they can make it through any other medications. Their cardiac clearances are very easy to do because they don't require problems with general anesthesia or cardiac anesthesia. So I think this is the landscape that we have to now incorporate medications into. The 2020 guidelines basically state as I mentioned, you treat the comorbidities, you decide if they're obstructive and how bad the symptoms are. You then give beta blockers or calcium blockers. I, again, go beta blockers and go right to disopyramide or septal reduction therapy. And again, you do not have to go through disopyramide to get septal reduction therapy. You can decide which way to go based on the patient's symptoms and tolerability. When you get to septal reduction therapy, here's the tree that I think makes a lot of sense and is shown in the guidelines. Are they a surgical candidate? If they're not a surgical candidate, then alcohol ablation is a class 1 indication. That's where you go. Not that you can go there, but you should go there. If they are a surgical candidate, then it really depends on whether they have any other surgical indication or a non-standard indication. If they do, then they should go for myectomy. If they don't, then you really decide between the two, and they're both class 1. So this is a major change in the guidelines where ablation and myectomy are always class 1. Just really depends on what else you need to do for these patients and whether you can get a good result with either. Now, I did write this here that I don't think that the guidelines paid enough attention to anatomy and hemodynamic indications to one or the other. For example, it makes it seem like only if you have to do CABG or have to do some kind of complex valve repair should you get myectomy. But the truth is, as I mentioned earlier, there is anatomy of the septum and about of the gradients that I think favors myectomy. And there are other anatomies, maybe focal basal hypertrophy, coronaries off certain areas of the coronary tree that really favor alcohol ablation. So I think hopefully further iterations of the guidelines will start incorporating some of those nuances. We published this also in 2000, when was this, 18 or 19, maybe 18 or 19. This is hospital volume and surgical myectomy or alcohol ablation across the nation. And a couple of things are important here. Again, we see that alcohol ablation has a much lower death rate than myectomy. Again, this is in an all-common population, not just in experienced centers. In experienced centers, it seems to be less than 1% mortality for both surgery and ablation. But in the real world, that mortality is very high in surgery and comes down as tertile goes up to higher volume. And same thing with alcohol ablation. Experience does count and mortality goes down. Pacemaker rate in the real world seems about the same. We do not see a difference in pacemaker rate between alcohol ablation and surgery in the real world. And again, the data I just showed in JACC interventions also speaks to that, because the average of 13 and 4% in that slide across gender comes out to about the same pacemaker rate in alcohol ablation versus surgical myectomy in the real world. Stroke is higher for myectomy, bleeding is higher for myectomy, and again, renal failure is higher for myectomy. This leads you to who should do these procedures. And in the new guidelines, they did come out with 3 tiers of institutions. A community practice or referring physicians, which should find these patients, try to do a good diagnosis and move them on. Primary HCM centers, which can do almost everything, but probably can't do but does not have capability of complex pediatric care, complex ablations, heart transplantation, and may not be able to do high volume alcohol ablation or high volume surgery. And then comprehensive centers that can do everything. I would say our center is one of these, Houston is one of these, Mayo Clinic, Tufts, and other places can do everything. And these are the ideal programs, because then I'm not deciding what I can do for the patient. I'm deciding what the patient needs, and then we just do it. It's a different way of thinking that is more idealistic for the patient. Because of that, I did also try to figure out where in the country are doing the most alcohol ablations. Per the guidelines, we want places to do at least 5 to 50 of these a year, 5 to 10 of these a year, and more than 50 over cumulative performance. And these are the programs at least 2 years ago or 3 years ago that met those qualifications. Houston Methodist is in there. You may be much higher than that now. I don't know. We have to redo this survey. Medical University of South Carolina, and we're doing about 40 to 50 a year today. But we also get from a lot of places in the area, and we're quite a lot of population in the Northeast. So let's spend a few minutes on the okay, so I'm going to try and end, so we have 10 minutes to spare. So another 5 minutes of this, and then I'll open up to questions. So these are the new medications, 2 new kids on the block, mavacamten, which we've been talking about for a couple of years now, and the new one, aficamten, the 2 companies you see here. Myocardia was just bought by Bristol Myers Squibb, so it's really Bristol Myers, and Cytokinetics. So can new pharmacotherapy delay or obviate the need for septal reduction therapy? I just told you why septal reduction therapy is good, and it's getting better. So can we have medications do the same or better in these patients? Will it produce the same observational improvement in mortality we're starting to see with septal reduction? So I published this a couple of years ago. This is looking at all the failed therapies in hypertrophic cardiomyopathy and where they work or don't work. So we've tried spironolactone, ARBs. We're doing more with ARBs now again to see perhexylene, ranolazine, eleclazine, and finally mavacamten and aficamten work here at the end in phosphate release. And myself and Dr. Daniels, Fusey, and Samsarian came out with this paper just this year. I hope you guys saw it. This is a paper in Circulation where we tried to compare how the muscle works in the heart to the engine of a car. Tried to be a little clever here, mainly because the myosin modulation seems to, for the first time, work on a different mechanism. And it's important to differentiate this from how we have used inotropes in the past, how we've used beta blockers in the past, how we've used the adrenergic system in the past to affect changes in hypercontractility or LV dysfunction. Instead, myosin modulation works on something else, as you'll see. This is the diagram we came up with. These patients with hypertrophic cardiomyopathy typically have, as I mentioned, more cross-bridging, and they have more myosin in the on state or the active state. Mavacamten puts the brakes on that and moves patients from a higher percentage in on or active state to the normal percentage in on or active state. And this is a new mechanism that can essentially determine what the level of contractility is in the patient in the sarcomere at baseline. So this is some of the preclinical data from mavacamten showing that in the normal heart, about 40% of myosins are folded back into what's called a super relaxed state. But in HCM, that number is reduced to a large extent. So very few sarcomeres are in their super relaxed state. If you look at what mavacamten and aficamten do, they improve that percent. So as I mentioned, 40% in a healthy heart should be in the relaxed, non-contractile, non-active state. It goes from this type, which is the basic HCM type, to with mavacamten, it almost normalizes that percent of myosin. So this gives an idea of how the medication can decrease the ejection fraction, the contractility, and hopefully improve diastolic dysfunction and perhaps other sequelae of hypertrophic cardiomyopathy. There is evidence that these medications can improve fibrosis in a mouse model showing fibrosis was improved. You have here the untreated patients, the treated patients, another patient, but then still, even with treatment, the fibrosis goes down but does not reach the wild type, which is the non-HCM patient. But even having some improvement here is interesting, how a medication may improve ultimately both contractility and fibrosis and potentially the degree of hypertrophy as well. They are potent in terms of negative inotropy here. We all know the pressure volume loops you see on the left side here. This is from AHA 2017. They moved that to the left, showing that you have, they moved that to the right, so they decrease contractility. The opposite of what we typically would want to see in a heart failure patient, but in these patients, we want to do that. There is a minimal to meager change here, as well here. And the cardiac output really in heart rate does go up a little bit. The main trial, the phase 3 trial that's come out with mavacamten is called the Explorer HCM trial. This is the trial here presented by Jacopo Olivato and Dan Jacobi on behalf of the Explorer HCM trial. Their primary endpoint showed this. About 37% of patients in the mavacamten group had at least a 1.5 millimeter per kilogram increase in peak VO2. Keep that number in mind because that's about what we saw with exercise, but is not the number we saw with alcohol ablation or surgery. So 37% of patients had an improvement, and that is far more, or at least double, what we saw in the placebo group. So it did meet its primary endpoint. Secondary endpoints you see here, there was a significant reduction in LVOT gradient compared to placebo as well. This schematic shows that a little bit more easily. The post-exercise LVOT goes down. The EF is about the same, minimal drop, but the resting gradient goes down and stays down to double digits. The provocable Valsalva gradient goes down. The BNP goes down, interestingly. So as an effect of hemodynamics of the heart, of the strain of the heart, seems to be improving that, the heart failure state. And even troponin seems to go down over time compared to baseline in patients treated with mavacamten. Importantly, these correlate with improvements in symptoms. So this is our mavacamten versus placebo. Most patients with class 2 in the Explorer trial, with some in class 3. So it was a relatively low risk patient population, our lowest symptomatic group. However, more patients became class 1 and class 2 in mavacamten group. It also had some improvement in placebo, as we oftentimes see as patients are managed more aggressively, but the differences were significant between the two. You can also look at it another way. How many patients had a complete response? So about 27% versus pretty much nobody in the placebo group had a complete response. So 1 in 3 patients may have a complete response defined as an NYHA class now down to 1, asymptomatic, and gradients all down to less than 30. So about 1 in 3 patients completely respond to the mavacamten escalating doses. I then presented the symptom questionnaire at ESC Heart Failure a couple months ago, maybe 1 month ago. Time is flying. This is the Explorer trial, but instead we put together a novel HCM symptom questionnaire, which is in press today. And we did this questionnaire at different time points to see, did the clinical benefits correlate with symptomatic benefits? The questionnaire had 11 questions. 2 of them were felt not to be good questions in reproducibility. And so we were left with these questions for shortness of breath, these 4 questions, as you can see here, okay? And that gave you a point scale. And if you look at the point scale, how these patients did over the course of the Explorer trial, the symptoms improved markedly. As soon as they took the medication and as they escalated doses and then reached a nice plateau. And then interestingly, when the medication came off, they went back to baseline. So that's an important point, that these medications really just work while you have them in your system. That's great, but they're kind of like pain medications where the pain goes away. But if you stop the medication, the pain will come back. It doesn't change the underlying problem, at least not in these trials. It is possible we're not catching these patients early enough and changing the underlying pathophysiology or the underlying substrate. That's the real question about these medications. But as they're devised right now and used right now, they seem to be more of an on and off in terms of symptoms and effects on the heart. 50% of patients responded based on the symptom questionnaire compared to 21% in placebo. Finally, the Valor trial is just now enrolling and finishing enrollment. We should have completed enrollment by next week, 100 patients. I'm on the executive committee here with Melinda Tsai as the lead and Steve Nissen as the executive committee site. That is basically looking at patients who are class 3 heart failure. So the real criticism of Explorer is it's class 2 primarily. So these would be class 3 heart failure patients who are going for septal reduction therapy. Take them out of that queue and put them in this trial for a few months, 4 months minimum, and seeing if you can obviate the need for septal reduction therapy. So will novel meds replace SRT? Regarding novel meds, they avoid invasive procedure and risks, such as pacemaker, VSD, bleeds, and stroke. Can save SRT for a later time. They may target both fibrosis and obstruction and prevent progression. Significant drops in EF may limit use, but lower doses are not as efficacious. Marginal improvement in NYHA class, as I already mentioned, and less than 50% seem to benefit significantly. Patients in trials had a relatively high VO2 at baseline, so they weren't that symptomatic, and the improvement was about 1.5. So you got to watch that and see, maybe the improvement was more in the more symptomatic patients. That has yet to be seen. And long-term data will take some time. For invasive therapies, the VO2 seems to be double, if not triple, especially given the sicker patient population. More significant and durable improvement in NYHA class, at least right now. Large clinical data and outcomes, including survival after 10 to 20 years. Many patients want to eliminate meds, not to add medication. It makes life safer and easier to not have the obstruction to begin with. Reduction in sudden cardiac arrest risk and mortality appears now in long-term data, and finally, the procedural risk will come down significantly. So just 2 slides on the future of HCM care. We do need to figure out, what do we do with genotype positive, phenotype negative patients, or genotype positive, genotype negative, phenotype positive. Can we eliminate, halt, or limit progression in these patients? Will medications do that? We don't have anything there. We need something there. The symptomatic patient with overt phenotype, can we eliminate the symptoms completely? Can we limit or halt progression? Can we reduce or streamline medications? Can we eliminate obstruction? And can we avoid invasive therapies? I don't think we want to do invasive therapies. We would want to avoid them if possible in patients. And finally, how about patients after septal reduction therapy? If they have residual gradient, some of them still need medications. They may have diastolic dysfunction still. They may have some cardiac arrest risk still. Can medications improve that as well? These are all questions that we need to determine. And the last slide I'll leave you with is that something you probably may not be aware of. There's a bunch of us that are in the process of starting a new society, a new professional society that we'll be calling the HCM Society. We're starting with a website. We got a grant to start this. And the idea really is that there are physician-facing organizations on the left, there are patient-facing organizations on the lower left, and there are companies now. And we do need a group of interested physicians to band together to try to make this work in terms of education, advocacy, and raising the bar and quality in a way that is transparent and firewall between all the different organizations. So these are the physicians that are involved in this: Dr. Ted Abraham at UCSF, myself, Dr. Olivato, Dr. Wong, Dr. Jacoby, Dr. Masri, Dr. Kasky, Dr. Martinez, Owens, Saberi, and Marin, and more to come. These are the initial group that is putting together an initial board for this, get it through, get our 501(c) going with the nonprofit status, and then finally launching this and getting more centers involved, including yours. So I will leave on that and thank everybody for their attention. And I think we have 5 minutes or so, or maybe 10 minutes for questions if there are. Thank you.
Right. Harry, thank you for an excellent talk. It was very informative. We enjoyed it very much. We have some questions coming in. Please remember to join us by text. Text DeBakey to 37607 and text in your message. If you're using a web browser, pollev.com, enter DeBakey in caps and respond to the activity to join us, of course. Dr. Nagueh, I think you have the first question.
So one of the incoming questions is about the proportion of patients with the disease who remain symptomatic and therefore justify referral to HCM centers of excellence for consideration of septal reduction therapy. What percent of cases, what's your experience with that?
You know, historically, we talk about half of patients can be managed with medications. You know, obviously I have a selection bias of patients who come to me severely symptomatic despite medication. So in our practice, a larger proportion end up getting septal reduction therapy. But I think the teaching is probably true because there's a large percentage of patients that have mild symptoms and some that have moderate symptoms and mostly provocable. These patients can have an important improvement in symptoms with medication. So I'd say half of them can be improved with escalating doses of medications, modest doses of diuretics, and also lifestyle modification, including hydration in those who need it, modest weight reduction. Patients can also limit their life in terms of eating less, eating smaller meals, trying to limit the splanchnic circulation and obstruction that happens from that so that they don't need septal reduction therapies. That being said, we moved as a field, as I mentioned, from trying to avoid septal reduction therapies to realizing that they're quite good and these patients do quite well and can eliminate medications and improve quality of life and prognosis. So the bar has moved. So if you have a place to refer to that does high volume with low complications, I think earlier referral is important and let those experts decide whether they can move to septal reduction therapy or not. And oftentimes, I will tinker with the medications, get them better, send them back to the referring, and then have the communication lines open with clear instructions to the patient and the referring on what would trigger referral back for septal reduction therapy. And I would not lose track of those patients.
Okay. Thank you, Harry. So we have a question from Sachin Goyal, my interventional partner. He wants to know, what's the role of percutaneous intramyocardial septal radiofrequency ablation? And if you could comment on its role and its effects compared to perhaps alcohol septal ablation or some of the other modalities we have.
Yeah, so what he's talking about is a procedure that I think was shown in China initially, and they have a small series, but there's obviously no randomized trial. This was a transapical approach of radiofrequency ablation that targets right to the septum. And the idea was that maybe you can avoid the heart block of these patients. But on the flip side, there's also the complications of a not quite minimally invasive, more like a apical approach, TAVR type of experience in these patients. So I think right now, it doesn't make a whole lot of sense to do that if you have alcohol ablation or surgical myectomy as an option in these patients because of the long-term data that we have with these over 10 to 20 years. I personally wouldn't do that unless there's no option for these other two techniques currently. I'm interested in hearing what you guys think about that as well.
Yeah, Dr. Nagueh?
The idea of targeting the correct site is appealing. However, when I think of the extent of the invasive approach with the radiofrequency ablation versus alcohol septal ablation, I find it harder to sort of go through that. I find it easier to talk to patients about alcohol ablation, even surgery, as opposed to through the apex of the LV and then target the area of ablation. Also, the long-term results, as you mentioned, Harry, are limited. So certainly more one would like to see more data before endorsing this as an alternative.
However, it might be nice for more mid-cavitary obstruction or areas of thickness that can't be approached as easily from alcohol ablation, or in patients with poor surgical options in mid-ventricle. Maybe we can evolve towards it there. But again, I see it as an add-on procedure if other things fail.
There is a question that came in, an interesting topic. You are aware of the CRISPR technique and the approach in animal models to treat HCM mutations by excising these pathogenic genetic changes, the base changes. Are you aware of research that is happening in that arena in humans?
No, I am not. But I think it's novel, and right now, the best way people are trying to do this, not by CRISPR, but rather, as part of pregnancy planning, is to determine genetic testing at the time of conception and to figure out if you want to have that take or not. But in terms of humans and CRISPR, no, I have not seen that yet.
I have a sort of an important question. You wrote it briefly. Can you comment on the effectiveness of the myosin ATPase inhibitors versus the septal reduction therapies, be it the extent of symptomatic improvement as well as the objective evidence in terms of peak O2 consumption?
Right. Yeah, I think we don't have head-to-head comparisons, and that's going to have to come probably one day. But right now, it does seem that the peak VO2 goes up about 20% with septal reduction therapies, as I showed you. And that's somewhere in the order of 4 to 6 points. Whereas with the medications, the endpoints were 1.5. And that gives you an idea. If they're using endpoints of 1.5, that's what they're predicting, right, as they make a trial. So it looks like, and that was happening in about a quarter to a third of patients. So it looks like the benefit you get with medications right now seems to be about 1/3 to 1/2 the benefit we ultimately get with septal reduction therapies, if you look at that metric. If you look at the symptom improvement, they seem to get a larger benefit in terms of the subjective improvement. And so there is, as we see in HCM, a difference between what you see in anatomy and physiology and what you ultimately see in symptom improvement in these patients. And so teasing that out is going to be very helpful. But it does seem to be not as beneficial, but it also might be because they're using class 2 as the majority of the patients, which may or may not have been asymptomatic to begin with and had a higher VO2 at baseline.
One last question. Septal reduction may reduce the late gadolinium enhanced mass. We can speak of that as replacement fibrosis. Presumably because that would be excised if present in the septum, say by myectomy. How do you see this affecting patients with respect to ICD recommendations?
Yeah, I think the septal scar or the scar burden in the heart certainly increases the risk of requiring an ICD based on sudden cardiac arrest prognosis and percent-wise. So we know that over 15% is a higher risk, 10 to 15% scar burden is a higher risk of sudden cardiac arrest. Whether excising that from surgical myectomy or ablating that with alcohol ablation and creating a homogeneous scar reduces, if that's the reason for reducing the sudden cardiac arrest risk in these patients, it's unclear. It's not clear whether just reducing the scar burden or replacing the scar burden with a homogeneous scar, or the effects on the outflow tract obstruction, or on the effects of the LVH itself, if the combination of those things is improving sudden cardiac arrest. That being said, where this comes up oftentimes is young patients who meet indications for ICD, such as a septal thickness of 3, but don't have any other indications. If you do a myectomy, and we know that improves the sudden cardiac arrest risk, what do you do about the ICD? Do they still qualify for an ICD? Does the myectomy modify that risk substantially to reduce the risk of ICD? Now, historically, we haven't said that. We basically put the ICD in regardless and used the pre-procedure risk stratification to guide whether they need an ICD. But nowadays, it's also reasonable to do things like putting in a loop recorder or reevaluating the patient afterwards. So that's an area of controversy. I think most places will still say that patient needs an ICD. In my practice, I'm probably a little more conservative about that, and I allow them on a case-by-case basis to do a loop recorder and more extensive monitoring to to see whether they need additional indications after the myectomy. But I'm open to seeing what you guys do at your institution as well.
Consider just the absolute LGE mass with respect to recommendations for ICD implantation. As you noted, there are many variables that come into play that one has to look at as well. Whether somebody goes for surgery and has a successful outcome or not in terms of reduction of LGE mass, I think that needs serial CMR exams to look at what happens to that mass to help inform better decisions. We are very fortunate that we had you this morning, and thank you for joining us. And we thank the audience for joining us, and this will be available on the Methodist DeBakey website for people to download it and enjoy that presentation again. Thank you for joining us this morning, Harry.
Thank you, Harry.
Thank you, Dr. Buergler. Thank you, Dr. Nagueh. Look forward to seeing you in person.
Same here.
Same.